Am I audible?
Walaikum Assalam. Yes, Dr. Kanwal.
Okay. I think there is something wrong with my internet because the voice is patchy. Okay, please let me know if there is any break in the voice. Leave a message here or leave a message on the WhatsApp group because my internet is slightly patchy today. Give me a minute. I'll keep my phone with me so that if there is any interruption, you would let me know. We are going to begin with the Occipital Transtentorial Approach today, and this is our second last session before we go on a break for the next month, inshallah ta'ala. And let's look at some relevant anatomy very quickly so that we can move to the surgical steps then. So it's really important to know why is this approach important, because it's not often used. I'm aware that in a lot of setups, this will not be a commonly used approach. Usually, where occipital transtentorial approach is used, we go ahead with the skid approach, right? But this is really handy when the lesion is supratentorial and is still around, somewhere around the pineal region, or the vein of Callan is pushed inferiorly and we cannot go through a skid approach. So occipital transtentorial becomes non-negotiable at that time. The access it gives to is basically the pineal region, the posterior most portion of corpus callosum, which has the corridor, right? This is the natural corridor. We use it. The only unnatural thing we do is cutting up the tentorium at its medial edge so that we can look below it as well. Otherwise, even if you don't do the tentorotomy, if you don't incise the tent, even then you can have some access to quadrigeminal cistern and, surrounding structures. Maybe not the deeper ones, but some access. Let's move to the next one. We are not doing the anatomy in detail because we have done it in the previous few sessions, but I wanted this image to be here so that, it's easier for you to understand. This is our corridor. Once we open it up, this is what we see. This is the splenium of the corpus callosum. You see all the major vessels, the vein of Gallen. This is the internal cerebral vein. And let's see the basal vein of Rosenthal. Then we have the trochlear nerve, which runs right around the tent. The tent has been incised here. And the basal vein of Rosenthal is somewhere around here. I am not sure if it's visible in this image. Apart from that, we have PCA and we have some branches of the superior cerebellar artery as well. So we know that this is the access we get once we go through this corridor, once we split the tent as well. You can see the pineal region located slightly superiorly. You can see the pelvinar, which is a part of thalamus, which has been dissected away. Okay, yes, I can see the basal veins here. And then we have the superior colliculus, the inferior colliculus. This is an approach which will also give some access to the posterior portion of the midbrain as well as the lateral portion of the midbrain. So it's a versatile approach, hence really handy to know. Let's move. This is another image of the same structures. It just gives a good vision of the tent, the angle of the tent and the tentorium. This is Fox, which is going above like this. This is tent here. This is the falcotentorial junction, which encloses the straight sinus. We have already done this. These are the venous lacunae, which are these venous lakes within the two layers of the tentorium. Apart from that, you can now see that all the structures we discussed previously, this is the vein of Gallen, which obviously continues posteriorly somewhere around here as the straight sinus. You see the internal cerebral vein, you see the basal veins, and cranial nerve 4, which is very important for us because it runs right around the tent. Let's move so that we don't end up. Indications, I'm sure you all would know. Any lesion around the pineal area or in the posterior third ventricle, it can be accessed via the occipital transtentorial approach. These can be pineal lesions. These can be germ cell tumors. And these can be meningiomas, especially falcotentorial meningioma or tentorial notch meningiomas, which are extending superiorly. Apart from that, if there are any midline gliomas, the high-grade ones, which arise around the posterior portion of the thalamus, the posterior third ventricle, tactile plate, or splenum of the corpus callosum, if there are solitary mets in this region, they can be accessed from here as well. You get the gist. Anything in this region, we can access it via here. Pineal cyst can be there, epidermoid and dermoid cyst, mostly dermoid because it's usually in the midline, then the arachnoid cyst. So, while I am talking about indications, do we have anyone who will let me know about the contraindications? Anybody?
More of infratentorial extension.
Okay, yes, that's a very good contraindication. Apart from that,
occipital lobe will be retracted, then the problems
okay, so another
related to occipital.
contraindication is if patient has the side on which we are operating on, contralateral to that, if patient has visual defect already, then that is a contraindication. We cannot go by occipital transtentorial because these are two occipital lobes, right? And on this side, patient already has some pathology, and now patient has vision loss. We cannot go via this side because this will essentially lead to homonymous semionopia or sometimes cortical blindness. If one side is already compromised, you end up compromising the other side as well. That becomes a relative contraindication. Apart from that, if galenic venous system has been moved superiorly, that becomes a relative contraindication as well. And yes, if the lesion has extensive infratentorial extension, that will be difficult to access from only the occipital transtentorial. For intratentorial extension, we will either need the BOT, bilateral occipital transtentorial transfall sign approach, because it will give some access to the infratentorial region as well. And the other option is to go via skipped. Let's move to the next one. So the steps, you all know. I hope anybody who has been listening regularly will not have a hard time with this. We know the patient position, it's either going to be concord or it can be semi-sitting. It can be park bench as well, depending on the surgeon's preference. There are people who will prefer semi-sitting position, but semi-sitting position comes with the higher risk of venous embolism. Concord is difficult for the surgeon. Semi-sitting is better for the surgeon in terms of access and everything. But Concord has lesser risk of ear embolism, so it's relatively safer for the patient. So you fix the head with the Mayfield skull clamp, and ideally we rotate towards the side of the lesion, because what is going to happen is, if you see, this is the, let me draw. This is the back of the head of a person. This is the fox. This is the tent. And let's assume this is the lesion somewhere around here. If we end up rotating on the side, the way I have rotated, then what ends up happening? The cortex is going to fall away with the help of gravity towards the other side. So we get natural access to this region. If you keep it neutral, you will not get the benefit of the natural gravity assisted retraction. Apart from that, yes, we want the head above the heart to promote the venous drainage and to minimize ICP. You know the gist. Let's move. This is an illustration of the concord position. Apart from that, incision is very easy to understand. It's horseshoe shaped. So there are these two authors. The books usually that is the operative cranial neuroanatomy. I'm not exactly sure if that's the name. It says to start in the midline. Ideally, you should start slightly off the midline, because what do we want? Let's see. This is the back of the head. This is the
Sinus.
midline. Fox, yes, that's right, Dr. Subban. We have sinus here. So ideally, let me mark along with the fox. We have the sinus here as well. So one point is if we start from the midline, which the text says we start from the midline in
We
neon.
cannot see the reflecting the dura. We cannot see the sinus. That's the main thing.
Yes, there is one option. If you undermine this portion, the medial portion, and retract it on the other side, then you still can keep the incision in the midline. On the other side, it ends around the mastoid process. Ideally, you should go slightly off the midline like this, exposing both the the superior sagittal sinus, and you will also have to keep in consideration the transverse sinus and the torcula. We are not planning to open the torcula. This is not for torcular meningioma. That would be very different. Let me change the color. So incision starts around the midline. Let's stick to that. Inion is the starting point. Mastoid on this side is the closure here. Then we retract the flap downwards. We incise through the skin, through the gallia, and we do the muscular layer. And after the muscular layer, we retract the periosteum fully. You can use self-retaining retractors. You can even if you're starting here, if you undermine slightly, you can most definitely put the retractors and create this space. But it will create some tension on the tissue. This is the textbook image. What I would prefer to do here is an incision like this, but this is the textbook. Your superior sagittal sinus is somewhere going to be here. And your transverse sinus is roughly somewhere around here. So you have to take the incision below the transverse sinus so that once you retract it and do the craniotomy, you will have access to both sinuses, even though you're not planning to open them. Are we all on the same page so far, or is it going too fast?
Yes, madam. Madam, borehole
Okay.
कहाँ मारना है? First borehole.
Sorry?
Where to put the borehole, madam? First.
No, we are coming to the craniotomy.
Okay,
We are
madam.
still on the skin. Let's move. This is the alternate incision, the incision that I was talking about, where we go slightly off the midline and end on the mastoid on the other side. Regarding burrhole, there are two options. Let's look at them. The illustration that shows this option, this is one. It's the similar approach towards the superior sagittal sinus in the interhemispheric approach. You have two options. You can either use two burrholes right on the sinus, or you can straddle, let me change the color. You can straddle the sinus with these two burrholes. I'm going to show you both options. It varies from surgeon to surgeon. What I have personally used whenever we have access to the superior sagittal sinus is this approach. One burr on this side, one burr on this side. We straddle it. It's easier, and I've personally find it relatively safer. But I know people who use this approach where they place the burr holes directly on the sinus, use a curved periosteum to detach the dura of the sinus and, complete the cuts. Let's move. This is the myocutaneous dissection. You see the muscle flap, which is reflected downwards. After the muscle layer, you do the subperiosteal dissection, take away whatever periosteum is there. And now you will technically have access to the transverse sinus and the superior sagittal sinus. These are two options that the book gives in terms of the paramedian craniotomy and the median craniotomy. Let's mark here. This is the paramedian craniotomy. This is the median craniotomy. Our goal is to do the median craniotomy because we are primarily studying this approach for falcotentorial meningiomas. So for that, we are going to have to do this median craniotomy, exposing the sinus as well. These are the second option that I was talking about that I personally use. We straddle the burr holes around the sinus and then the other burr holes. Then we create a bone flap. making the cuts around the sinus as the last ones. Let's move, we are running out of time. After the craniotomy, and you can see that they have used the single burr approach, because you can see this burr here and this burr here. This is the single burr approach. Apart from that, you can see the transverse sinus here, the superior sagittal sinus here. So our goal is to make this inverted T incision into the dura. Why? Because we want to secure both sinuses. We do not want accidental entries into these sinuses, and we do not want to disturb any cortical or bridging veins which are going in these sinuses. Am I clear so far?
Yes, madam. Yes, madam.
Okay, just give me a minute. So what we do is we make this incision, and once we have made this incision, we retract this flap on this side and this flap on this side. What that does is they have actually cut the flap from here, but you will have to imagine that this flap goes on this side like this and so on. So this portion is secure and this portion is secure, and there is no accidental entry into any sinuses. Apart from that, what is other major concern? They have not shown it in this image, but as a surgeon, I would be very concerned if there is any opening into the mastoideo cells. If I see one, I'm going to make sure that I'll pack it with the gel foam, with the muscle. We use muscle to pack the sinus usually. So we pack it so that there is no CSF otorrhea postoperatively. It's a very small step, but if you end up exposing the ear cells and you forget to pack them, then usually this will be a really big problem for both you and the patient. After you have opened up the dura, and you can see that they have removed the flaps which we were using to sandwich. After we have removed the dura, you can see the occipital pole. I'll very quickly show you the anatomy. We have the calcarine sulcus here. So this is the superior calcarine gyrus. This is the inferior calcarine gyrus right around here. This is the inferior occipital gyrus. This is the superior occipital gyrus. If you're working on the dominant side, you know that this is the primary visual cortex. And even though the approach here in this region is a natural corridor, just like interhemispheric approach, you will still have to retract some portion of the occipital lobe until and unless the lesion is big enough and it is already causing some displacement of the cortex. If that happens, you are very lucky and the patient is very lucky. Otherwise, the safest approach to go in this region is to use dynamic retraction. Never use Lala retractors or the fixed retractors that you just put on these cortexes. They will cause these microscopic contusions, and patient will have a permanent deficit. To avoid that, only use the handheld retractor very gently with the help of cotton patties. Fixed retraction is never a good idea if you want a good post-op outcome. We have discussed this image before in the falcotentorial meningioma session, but it was a beautiful image, so I decided to put it back. You can see all the structures and the actual corridor we will be into. The craniotomy, let's create the craniotomy here. This is our craniotomy, and rest of it is, nothing of it is visible to us. I'm closing it up so that it does not confuse you. And obviously this is a cadaveric section, so they are retracting quite apart. We don't have the liberty to do this. What we do is we retract it gently, and you can see the straight sinus around the junction of the tent and the fox. This is the fox, this is the tent. There is this 90-degree, almost a 90-degree angle. And right around here, we have the straight sinus. And we know if we go in the depth, we are going to see all the major vessels. How do we do the tentorotomy, which is the question of the day? For tentorotomy, there are two considerations that we need to have in our mind. What is that? First is the cranial nerve 4. And the other thing is venous lacunae. We know that tent has, even though it's not visible in this image, it is somewhere around here. So tent has these venous lacunae, venous legs, which are going to bleed, ooze, and pull up in our surgical field. Apart from that, right at the end of the tent, right at the edge, we have the cranial nerve 4. You cannot see it in the image below. This is the edge of the tent. Right around it, we have the cranial nerve 4, the trochlear nerve. So these are the two considerations. We have to protect these structures at any cost. How do we do that? Let's see. We go 1 to 1.5 centimeter away from the straight sinus, right around here. We bipolar this region. Once we bipolar this region, we create a very small nick in this region. Never at the edge of the tent. It's too deep and you don't have direct vision as of yet. So you bipolar in this region and then you give a small nick and then you proceed in the superior medial direction because the tent is like this. You have the cerebellum around and you have the occipital cortex. Tent is superiorly. So your incision is going to be directed superior-medially. Please remember that. Bipolar, create some space, give a small nick, use magnification as good as possible, and then give this incision in the superior-medial direction and incise the edge of the tent under direct vision so that you do not end up compromising cranial nerve 4. Once we are done this, you can see in the last image, this one, P, that they have incised the tent, and obviously it's a cadaveric image. You can see the vein of Galen, you can see the pineal gland right here, you can see the internal cerebral veins, and the superior vermium vein, you can see it's away from the straight sinus. The straight sinus is intact here. It will give us access to the superior surface of cerebellum and this quadrigeminal cistern region. This is a cadaveric section. In a normal human being, you are going to find a lot of arachnoidal membranes here. You will have to visualize it. And I would strongly suggest if you can go and watch a video of Occipital Transtentorial Approach. There will be a lot of whitish adhesions. These are arachnoid membranes. You do this arachnoidal dissection very gently to open up the space because there is going to be quadrigeminal cistern around here. Am I clear?
Yes.
Am I clear?
Yes.
Yes.
Okay. This is an overview of everything we have discussed so far. You see the craniotomy and the incision. Apart from that, you see the dural incision. They have used this inverted T. What I have used or I have seen used is this one. So there can be, different differences of opinion in how people open the dura. Once you open the dura, you can have access to the tent. This is just an illustration of the previous cadaveric image. You have the fox here, you have the tent here, straight sinus. This is the region where you are going to cauterize and then create your first incision. Let's look ahead. I have included the link of the article that I have used this image from. It was a beautiful intraoperative image. And if you take a look, you can see the straight sinus here. This is let me say, which one is the superior portion and which one is the inferior portion. Apparently, this looks like fox and this looks like tent, but I'm not 100% sure. Please don't quote me on this. This is the straight sinus, and you can see here they have preserved the straight sinus and bipolarized this region, this small region around the tent. And let me clear this. After they have bipolarized, they have created a small incision in the tent, opening it up and visualizing this spinal lesion. This was an article for a spinal lesion. But the steps relatively remain the same. You have to know how to do the tenterotomy. This is just a run through of all the previous steps we have covered on the images. So these are just text, you know, by this point in time, how we do the surgical approaches. We have two burr holes over the sinus and the transverse sinus, taking care to not lacerate the venous sinuses. You know the approaches, we either go via this way or we go via this. So you know that. Then we elevate the bone flap. After elevating the bone flap, obviously we use the bone wax, we pack any active bleeding, we pack any exposed mastoidea cells with bone wax or muscle. And a good idea is to take off all the bone wax which is extra. If you leave excess bone wax, it can be a cause for postoperative infection. So we have to find a middle ground. You have to prevent the post-op CS of rhinorrhea, but you also not have to leave excess bone wax around there. If we know the dural opening, U-shaped or inverted T pattern, we reflect one leaflet towards the superior sagittal sinus, the other leaflet towards the transverse sinus, so that both are secure. Then we take the dural checkups so that there is no oozing which is going to cloud our surgical field. Then we bring in the microscope and we retract the occipital lobe very gently using cotton patties. And there's no aggressive mechanical retraction, no fixed retractors, especially in the occipital transtentorial approach. And then we just follow the fox. Fox is going to show the way. We have discussed this thoroughly, how to give the tentorial incision. It is also called tentorotomy. If somebody wants to go extra fancy, so we have to find a safe avascular zone, 1 to 1.5 centimeters lateral to the straight sinus, making sure there is no venous lacunae in there, and making sure we are close to the edge, but not too close. We bipolarize it, make a small puncture, hook it up, and give rest of the incision under the vision. After we have done this, we can reflect it, and there is no need to sew back the tentorium if it is not hindering any structure directly. And then obviously you have to open up the arachnoid of the quadrigeminal cistern. If you're going lateral, then you will find ambient cistern as well. There is no question on the preservation of the galenic venous system and the deep venous structures, the internal cerebral vein, the basal vein, PCA, and sometimes even the branches of superior cerebellar artery if you go deep enough. Once we have resected the lesion, the next goal is to achieve hemostasis, making sure there is no oozing from any of these smaller veins, from the tent, especially the tent. And because this is a small area, and any bleeding here is going to create more problem, a problem which is bigger than the size of the bleeding itself. You do not need to resuture the tent, usually. And if tent is involved in the meningioma, then you can even take some portion away without having to replace it with a graft. But if it won't be possible with this approach, but if you're using bot and you take away a big chunk of the tent, then you can repair it obviously with a dural replacement, like Duragen, etc., or maybe periosteal flap. If you have taken out big enough chunk, simple incision does not need any intervention. Our goal is to close the dura in a watertight manner because we have opened up the cistern and we do not want CSF leak as a complication. And that's it. We just close. That's it. That's a wrap for today. Any feedback, any questions, they're all welcome. Tomorrow is our last session before we go on a break. Do we have any questions?
Madam, the durotomy, we do not tend to give incision. Where to give incision? सॉरी, हाँ, टेंट में जो इंसेंट डालते हैं तो एग्जैक्टली कहाँ पे डालेंगे?
I spent significant amount of time. Is it not clear? Let's go back. Let's go back. Let's look at this image. This is the straight sinus, right?
Yes, ma'am.
You have to bipolarize the space.
Black
I'm
color.
using this white color to for you to understand this. You have to bipolarize this region. In
Yes,
fact,
madam.
slightly more anteriorly, you have to bipolarize this region 1 to 1.5 centimeters lateral to the straight sinus. And once you
Yes,
do
madam.
that, then you can give an incision here, a small incision. After that, you take a small suture and retract it towards you so that there is some space and you do not end up dissecting the superior vermian vein, which is just under the tent. You have to remember, just under it, we have the cerebellar surface and the superior vermian vein. So we retract it and give the rest of the incision under our direct vision so that we do not hurt any structure underneath it. And we take it forward in the superior medial direction to protect the cranial nerve fold. Is that clear?
Yes, madam. Yes, madam. Thank you, ma'am.
Okay. Yes, Dr. Shahid, this obviously is an approach for panel region as well. I'm not sure if you joined in between. And there was a specific slide of indications where we did discuss that anything around the posterior third ventricle, around the pineal region, it can be accessed via the occipital transtentorial approach. I will leave a PDF handout. I will see if I can manage a PDF handout and upload it on the drive along with the PPT. Do we have any more questions? Okay, that's it for today. Thank you so much. That's a
Thank you,
wrap,
ma'am.
everyone. Thank you.
Thank you.